Our first speaker of the day is Professor Dr. Amjad Cheema. He is Professor of Surgery. He is Director of European Academy of Robotic Colorectal Surgery. And he works at Poole General Hospital. He now travels a lot. He goes to Europe, all over the hospitals. He works in Lisbon in Portugal. He does some philanthropic work there. And he is a great teacher. He has been to our hospital where I work in Tameside Hospital to teach our colorectal surgeons. So I invite him. He's going to present improving short and long-term outcomes of the colorectal cancer, the impact of technological advances. Professor Dr. Amjad Cheema.
Thank you very much for the kind introduction. Assalamu alaikum, everyone. I'm the first speaker, and one of my former bosses when I was a trainee said the best time to speak in the Congress is the first speak in the morning, because half of them probably won't have been woken up, and by the time they remember why they're here, your presentation is finished. So I work in Poole. Poole is south from here. I know most people from Midlands and up north come to London and think word finishes in London. There is a bit of a word further down south as here. Or in my introduction, it was mentioned that now I do 2 weeks of every month in this place in Portugal, Lisbon. This is Shimpalimo Foundation. This is an institute which is a non-profit organization set aside for delivering cancer care. So I'm responsible for minimally invasive GI surgery there, and I've been involved in this work for nearly 3.5 years now. This is what I thought I'll talk about. I'm not going to bore you with a lot of stats. How many of you are surgeons? At least I've met one who kindly came, and so I know that at least one in the audience is surgeon. There are a couple of others. So surgeons are very simple-minded people. They really don't need to sort of see a lot of data. I'll talk to you about what has been the innovation, at least in the last 2 decades since I've been a practicing surgeon within my specialty, and why there have been hurdles in adopting new technologies. Why people are reluctant for change. Change often is perceived as a threat, and people do not want to change, and it was nothing new for colorectal surgery as well. And then I'll just sort of finish off by giving you some example of how I have been part of a process to bring about change, both at the local level where I worked, both at nationally and some international projects. Sorry, this is very early in the morning. This is how abdominal surgery conventionally is done. If it all heals very nicely, it looks very nice on the left, you could see. But occasionally we do know that there are problems with larger wounds and people stay in hospital for a long time. I mentioned change. Change is inevitable, and we can try to resist it, but eventually it would happen. Some of us know this change very well. Now, risk of having a heart attack is directly proportional to the width of your TV screen, and that is quite true. Things have moved on within my specialty. Now we do most of elective colorectal cancer resections using laparoscopy, which is available nationally and worldwide. And in recent years, there has been an increasing adoption of robotics within the specialty. But it really wasn't like that in UK. This is what colorectal surgery doing laparoscopically was perceived from some of the big opinion leaders within this country. We were under spotlights, and often it was referred as murder in the dark, because you need to have a sort of a dark room where you can look at the screens. And it all sort of was like this. But it all changed over a period of years. There were a number of trials that came through. Classic was a trial run within this country for about 5 years. Color 2 was a European study. Korean study obviously came from Korea, and then there was Spanish trial. And all it showed that this perhaps is safe. It is associated with less blood loss, less pain relief, early discharge, quicker recovery to normal functional capacity of their lifestyle before they came in. So this was sort of put to touch, and everybody agreed, okay, laparoscopy is perhaps better. Then the big question was whether this is reproducible. I'm just going to share with you a 10-year worth of work that I was involved in Portsmouth before I moved to Poole. This is looking at intraoperative complication, conversion to open surgery, operative time, post-op complications, so forth. People who are non-surgeon within the audience The conventional length of stay associated with a midline incision nationally is about 14 days. Then we introduce ERAS, which is Enhanced Recovery Program, and we cut it down to 11 days. So this is 70% of work nationally done in this country is done through conventional open surgery for elective cancer. So this is where the goalpost is. We are measured in UK. We produce ACP GBI is our professional body that produce public domain clinical outcome data with named surgeons, so people could be tracked. It is in public domain and people can see who is killing how many every year. So I looked at this consecutive 1,000 cases within my practice when I started it. The reason I'm presenting this data to you more so is that I was invited to Portsmouth to come and set up laparoscopy, a center which didn't do much laparoscopy before. I was invited, so it was almost like a rope given to me that I can hang it with myself really if I don't get it right. This is the demographics, as you would expect. Vast majority of these were done for cancer, as you would expect, and then 262 were done for various benign conditions. There are different types of procedures. If you are a GI surgeon, you would recognize some of it. If you don't, it's not the test. The idea is that you could apply laparoscopy across different procedural indications. These were the outcome. This is published data now. Conversion rate to open surgery was 1%, anastomotic leak rate 1.7%. Median length of stay for consecutive 1,000 patients was 5 days. So imagine we knocked the median length of stay within our hospital from 13 to 5 days. And I thought, this would mean pretty good. We would be asked to come down and meet CEO and perhaps be patted to the back. What happened to the back of this? They closed one of our wards because they thought that we can deliver the same service with shorter number of beds. So we really don't need extra beds. So that's the price of progress. Progress is sometimes double-edged sword. Mortality rate within those 1,000 patients, 0.29%. This is cancer resections. If you're a cancer surgeon, we are measured with how completely you can take cancer out, which is R0 resection rate, and number of lymph node is 12, which is bare minimum needed for pathologists. These are the list of complications that happen over those sort of 1,000 patients. If you operate enough, you would have complications. There are only two people who usually do not have complications, people who don't operate or people with short-term memory loss. And surgeons are gifted with both. This is one of the papers that came out of our data. This is looking at high-risk patients. So it was not applicable for select few easy cases. Can you apply it across the board to people with ASA grade 3, people who had a BMI of 30 and over, previous abdominal surgery, and so forth. And this was published in Annals of Surgery a while back, showing laparoscopy was a better tool when compared to open surgery. Rectal cancer is slightly different than colon. This is rectal cancer data. You would see that all of this is well within respectable numbers. This is interesting. This is long-term data, comparative data looked at by Bill Heal's data. I'm not expecting you to know Bill Heal. He's a colorectal surgeon who retired from Basingstoke, who introduced the concept of total mesorectal excision back in the 70s and 80s. And like most things, he was heavily criticized when he came up with these best figures. Our data is sort of second row here. Mark Bullock wrote this paper with me. So you can look at long-term survival and disease-free survival is pretty respectable. So laparoscopy not only produced better short-term outcome, we have looked at long-term outcome for rectal cancer, and we were able to demonstrate that this is possible. I'll get out, just because we couldn't upload it, just for people who haven't got an idea, for example. So I'll just show you, I'll run it past, don't worry, I'm not going to show you the whole video. So the idea behind laparoscopy is most of this is done with small puncture wound ports put in different places, and you use a straight instrument standing next to patient. This is monopolar hook that we use in our practice. Idea behind that is you isolate the main feeding artery. This is rectal cancer being done. If you can name the artery, you should clip it, then you'll sleep better. Then you take artery, you mobilize the bowel going medial to lateral plane, which is dividing the vein now, developing medial to lateral plane, just staying in front of the top of the kidney. The minimal amount of blood loss associated with laparoscopy is somewhere around 10 mils, really. This is a procedure who conventionally was associated was a median blood loss of about 500 mils, generally speaking. This is a monopolar current. You could see it's been done using straight instruments, which is laparoscopy. I use monopolar hook. There are different types of things available. This is the left hypogastric nerve in pelvis, very important for sexual function for men. Women, it control bladder function. So with a 3D or HD view with laparoscopy, you are able to see it much more better. So you are likely to save this or not to damage it. Idea is that you go as low as possible, get below the tumor, and then divide it using a stapling device. So this is a stapling device. Cancer is around this area here, which is marked with top of the blue ink. We use stapling device with 2 firing, and you can divide just above your anal sphincter. So you can get lower than you would conventionally get with laparoscopy, which means less permanent stomas, and then you would have a better urological and sexual function, particularly for men, if you could save the nerves. So this is an idea of dividing it in 2 firing. This is anal canal, and then you sort of do, once you've taken the specimen out, you bring the spike out. This is for non-surgical colleagues to give them the idea. Now the bit has been removed. This is the normal bowel proximally. This is the head of the gun. So this is all innovation happened in the last sort of 15, 20 years. Imagine some of you, I hope that none of us remember the long parachute incision, sutures being done down to the bottom end, which I used to see as a house officer in Mayo Hospital. So this is laparoscopy. What about robot? Robot is different. This is an idea to give you a robotic. So you put ports in, 4 metal ports in. Oh, I'll just shut the volume, which is okay. You expose the bowel, and once you have the normal exposure, this is an XI system, which is the latest version of the robot that is available now. And you dock the robot onto the patient. This is laser guided docking system. So all you need to dock is this plus on the camera where you want it. And once you've done the docking, the computer would work out where the arms have to go to minimize clash. You can see that now. Now a surgeon sit on the console. It's the same operation I've shown you with the straight instruments. Here you could see it's a precise, much more precise dissection down to millimeter, because you are looking at 3D console immersed. So you almost can see blood running into capillaries as well. I'll fast forward this to give you an idea. Operation remained the same. You isolate the artery, you clip the artery, you cut the artery, mobilize the bowel, take the vein, and once you've gone past, this would give you an idea. Sorry, I'll just sort of run this past to give you an idea what surgeon is doing. Surgeon is sitting on the console far away from the place. You are sitting comfortably. You can see the robot working on the patient. Assistant really are there for a showcasing. They have very little input really, and more this little input will become less and less. Then you are just using your hands as a paintbrush exercise. You can angulate more. You can get into the tight, narrow spaces. Same is true for esophageal surgery. Same is true for rectal cancer surgery. So you get the idea, for in terms of what I was trying to sort of say. I'll run through this and finish this off quickly. So this is available in public domain. This is how surgeons in England are measured. So if you type in surgeon reported outcome for colorectal surgery, it would show you how many people you have had a chance to kill. This is 90-day mortality, by the way. So I think this is playing up. Okay, so I'll just sort of get out. My colleague has probably got the control. Okay. Right. Evolution in surgery. I'll just talk a bit about something and then I finish it off. This is robotic procedures now, moving on to robots. This is a European academy which is based in Portugal. And there are about 11 centers participating. This is a Korean study showing robot being a single denominator responsible for better long-term survival. So it is associated with better outcome if you do it robotically. These are all the survival curves and graphs comparing laparoscopy with the robot. Just few words about this. This is the concept. The idea is that people are trained using a supervised proctoring program for up to 10 cases. Once they have trained about 10 cases, they are asked to submit 2 DVDs which are assessed blindly to give them accreditation. This is how they are assessed. The idea behind this was to set up centers all across Europe. This is 107 delegates now currently being trained within Europe, different countries, well represented through most of the places. There are 350 proctored cases now, 62 cities, 16 countries. These are the graduates who have already finished the program. 50 people have already graduated through the program. I'll finish off by showing you this thing. People talk of progress and reluctance to change. Do you know who this guy is? This is Yuri Gagarin. This is the first man in space. If you remember his story, I have an interest in history. So I remembered his story that when he had a re-entry phenomenon, when he came back from space, he missed his mark by 250 miles. And he nearly died in a re-entry. And he ended up somewhere in Kazakhstan in the village. Before he came out of his capsule, walked to the village and told them, I'm the guy who's come from wherever. And then the Russian media had to keep him there to make a show of it. This is the caption in US at the time. So you people would say how this is related to progress. I'll show you something like this. This is the picture taken from Curiosity when it landed on Mars for the first time, and it looked back where it's come from. So Earth is the first little dot, then it's Venus, and it's Jupiter. Just to give you an idea of when something starts, don't look at what you're going through. Look where it would lead you to, and this is true about innovation, because only change is eternal, perpetual, and immortal. I'm grateful for the invitation.
We are running, thank you very much, Professor Amjad Cheema. We are running quite late. So any one question, any hot burning question? Please, Dr. Sohail.
Sorry, what is the safety protocol or safety profile of robotic surgery as compared to human operated surgery?
Yeah, so the number of studies, that's a good question. So number of studies are done so far looking at surgeon fatigue associated with the near misses and error rate. Currently as it stands, what I've shown you really is not a true robot. This is a master-slave concept. So you sit on the console, and when you use moving your instrument, it would only do what you are doing from the console. So what I'm trying to say is that if you do it badly, your mistakes would also be in 3D HD for everybody to see. So you won't be able to do it very long. But we have looked at now things like automation, look at surgeon fatigue and completion of the task. A robot is obviously much more better because it doesn't get tired. It doesn't have to go home at 5 o'clock. It doesn't have a child care to look after. So this is shape of things to come. Shape of things to come is automation, where part of the operation would be done purely by the robot, while surgeons sit on the console just like autopilot, just making sure that the numbers look the same.
Thank you very much.